issue because it is very useful. And in the Women's Health magazine, Top Doctors for Women, 2008. She does a lot of service work, a lot of presentations all over, like the one that she's doing tonight. She's a noted author, in particular a book titled How to Keep from Breaking Your Heart, What Every Woman Needs to Know About Cardiovascular Disease, and Beating and Treating Heart Disease, A Consumer's Guide to Cardiac Medicines. She's also written numerous publications. It is certainly a privilege to have her here tonight with us. Please give her a round of applause, Barbara.
Can you all hear me? I want to thank Dale for that kind invitation. I want to thank the Department of Women's Studies and the URI Nursing School for inviting me to give this lecture. I'm really honored to be asked. I direct the Women's Cardiac Center at the Miriam Hospital, and I'm privileged to work with two extraordinary nurse practitioners who both are alumna of URI. Patty Shea Leary graduated from the nursing program at URI, and Joan Brennan got her master's here. I'd like them both to stand up because I want to honor them. Nurses are the heart and the backbone of the healthcare system. And I can't thank you all enough for the care you take of our patients. I also want to thank the Department of Women's Studies. I like to say I've been a conscious feminist since the early 1970s when I was a resident at Yale. I was probably born a feminist, but it didn't become conscious until I was a young house officer. And I'm going to talk to you tonight about a subject that's very near and dear to my heart, and that is gender-specific aspects of heart disease. Now, my objectives are to present a comprehensive introduction to heart disease, especially as it affects women, to discuss some gender differences in heart disease symptoms and risk factors, to summarize lifestyle and medical approaches to the prevention of heart disease in women, and to bring about world peace. Actually, that last is from another lecture, but I thought I'd slip it in there to see if you all were awake. So, who is this man and what is he doing in my presentation? I don't really expect you to know who this is unless you happen to have majored in English history. Any English history majors here? Well, this man is William Heberden. And William Heberden was a very well-known physician in London in the 18th century. And in 1768, he gave an address in front of the Royal College of Physicians. And like all learned physicians of his day, he spoke and wrote in Latin. And he gave a talk in which he described a new syndrome. And I'm going to tell you what he said, but in English because my Latin is very rusty. William Heberden said, "But there is a disorder of the breast marked with strong and peculiar symptoms, considerable for the kind of danger belonging to it, and not extremely rare, which deserves to be mentioned more at length. They who are afflicted with it are seized while they are walking, more especially if it be uphill and soon after eating, with a painful and most disagreeable sensation in the breast, which seems as if it would extinguish life if it were to increase or to continue. But the moment they stand still, all this uneasiness vanishes. The seat of it and the sense of strangling and anxiety with which it is attended may make it not improperly be called angina pectoris. Males are most liable to this disease, especially such as have passed their 50th year. I have seen nearly 100 people under this disorder, of which number there have been 3 women. So right from the get-go, even before we knew that angina pectoris, or angina pectoris, was a symptom of heart disease, the feeling was that this was really a problem for men. So although he didn't know it, William Heberden was the first physician to write about a gender-specific aspect of cardiovascular disease. Now, when I was in medical school, my professors took what I like to call the bikini approach to women's health. everything except what's covered by a bikini was felt to be the same between men and women. And it's only in about the last 2 decades that we've come to discover that, lo and behold, our hearts are also different. But really, this shouldn't surprise us very much, because we know there are gender differences in perception. 99% of women who look in the mirror see someone who's 30 pounds more than she really is. And 90% of men, even if they weigh 300 pounds and have warts on their nose, look in the mirror and they're pretty sure that they're an attractive fellow. This seems to be particularly true of Rhode Island Italian Americans. And I can say that because I'm married to one, but he really is very handsome. So there are gender differences in perception, and there are gender differences in priorities. Here we have a woman who's choosing a half-price sale over water in the desert, and a gentleman who's choosing chicks with large American breasts over water. So there are gender differences in lots of areas. But in order to give you some background for talking about gender differences in heart disease, I want to talk about some basic facts about your heart. And your heart is a muscular pump. Its job is to pump blood around the body. And like all pumps, it needs energy. And it gets its energy from the oxygen in the blood, and it gets its own blood supply from 2 little arteries called the coronary arteries. There's a right coronary artery and a left coronary artery. And the left divides very quickly into 2 major branches, the left anterior descending or the left circumflex. So those of you who are my age may have some friends who've had a so-called triple coronary artery bypass graft, or triple cabbage. And what that usually means is that the right, the left anterior descending, and the left circumflex coronary artery have all been bypassed to get around some blockages that have occurred in those arteries. Now, this is a schematic of the cardiovascular system. And I want you to remember that arteries carry oxygen-rich blood from the heart to all the cells in the body. So your arterial blood is rich in oxygen, and it should be rich in nutrients. Veins, on the other hand, bring blood back to the right side of the heart after the arterial blood has given up oxygen and nutrients to the cells. And the venous blood then gets pumped by the right side of the heart into something called the pulmonary artery, which divides into smaller and smaller branches until they're finally little microscopic branches called capillaries. And in the capillaries of the lung, oxygen gets picked up by the blood and carbon dioxide is given off. And this circulation of the blood continues uninterruptedly throughout your life. In fact, if you have a circulatory arrest for more than about 5 minutes, you're not going to survive, or you're going to survive with severe brain damage. Now, underlying most of the heart disease we see in this country and indeed around the world is a process called atherosclerosis. Now, atherosclerosis is one of those big words that doctors like to use because it makes us sound smarter than we really are. And atherosclerosis is derived from 2 Greek words, athera, meaning porridge or gruel, and scleros, meaning hard, because the early pathologists who looked at these diseased arteries thought that the buildup of what we now call plaque looked like hard porridge. So it sounds fancier to say you have atherosclerotic cardiovascular disease than you have hard porridge disease. So as you can see, if you slice an artery and look at it en face, normally you have a big opening, that blue area, what we call the lumen. And then atherosclerosis actually starts in the wall, and this yellow material is a diagram of plaque. And over time, the plaque becomes more and more severe to the point where the artery can be severely narrowed. So the more plaque you have, the more narrowed your arteries are. But that's a schematic demonstration. And what I want to show you is the aorta from a 12-year-old boy on the left. Okay? This is a 12-year-old American boy. And those arrows are pointing at what we call fatty streaks in the aorta. These are the earliest signs of atherosclerosis. So in America, many, many children already have signs of atherosclerosis. The aorta on the right is a severely diseased aorta. And all that irregularity and nodularity is buildup of plaque in an aorta. Now this is a schematic of a coronary artery. Down here in the lower left is the aorta, and this heart has been sliced. The artery's been sliced longitudinally, and you can see the beginning part there is quite open, but then as you go farther and farther down the artery, and I do have a pointer somewhere, you can see more and more plaque affecting that artery. I'll find it. Here we go. Here's the artery coming off the aorta. Here's the plaque starting to build up. And if you follow this down, you can see that the opening, or the lumen, is just a pinpoint there. So this was someone who died of a massive heart attack because of plaque in his coronary artery. Now, what's the scope of the problem that we're talking about? 8.4 million women in the United States currently have coronary heart disease or coronary artery disease. 10% of all women between the ages of 45 and 64, 25% of women who are age 65 and over. In 2006, almost 400,000 women in the US had heart attacks, and 9,000 of them were under the age of 45. Every year, 43% of deaths in American women is caused by cardiovascular disease. In 2006, 65,400 women died from heart attacks, and that was 6 times as many as died from breast cancer, even though most women, or a lot of women, think that they have a better chance of dying of breast cancer than heart disease. Now, there are a lot of myths about coronary artery disease. The first myth is that it's a man's disease, and certainly when I was in medical school, it was taught as a disease of men. The second myth is that women have the same risk factors as men do for developing atherosclerotic cardiovascular disease. The third myth is that women have the same symptoms when they develop coronary artery disease. And the fourth myth is that women are treated the same as men. The facts are that in this country since 1984, more women than men have died of atherosclerotic cardiovascular disease every year. And this year, about 50,000 more men than women will die. More women than men will die of this disease. There are some risk factors which are specific to or more dangerous than women. Women's symptoms are described as atypical, because of course what happens to men is typical. And women are treated differently, and I'll show you some proof of that. So I'm going to talk a little bit about symptoms of coronary artery disease, because that's one of the ways that men and women differ. As I talked about, this symptom of angina pectoris was first described by William Heberden, and angina means strangling or choking in Latin. He didn't call it dolor pectoris, pain in the chest. And I try to teach my students, if you're trying to diagnose angina, don't ask patients if they're having chest pain. Because most of the time when they're having angina, they'll describe it as a squeezing or a burning or a pressure or a hot feeling. But the hallmark is that it's predictably brought on by exercise or emotional stress, and it goes away within a few minutes with rest, relaxation, or a medicine called nitroglycerin. It can occur in locations other than the chest. It can occur in the jaw. It can occur in the back. It can occur in the shoulders. But again, the hallmark is its relationship to exercise and stress. Now, angina, again, is caused by an imbalance between blood supply to the heart and the demand of the heart for energy, for blood supply. When the heart is not getting the amount of blood it needs at that moment in time, that condition is called ischemia. It's one of the words I fell in love with as a medical student. It sounds like it should be a Russian resort on the Black Sea, right? But it's not. It's not something nice. It means your heart is starved for oxygen. It's like trying to run your car with an empty gas tank. When your heart's ischemic, it's not getting enough fuel. How does angina differ in women? Well, women are more likely than men to have angina at rest. They are more likely than men to have angina wakening them up from sleep. And they're more likely to have angina with emotional or mental stress than men are. Women have a more benign prognosis. They have a better outlook if they have angina before the age of 65. Now, these data were derived from something called the Framingham study. The Framingham study is a very famous study if you're involved in medicine. After World War II, the government suddenly realized that they were having an epidemic of heart attacks. So they decided to try and find out what the risk factors were for developing heart attacks or atherosclerosis. So they enrolled 2/3 of the population of Framingham, Massachusetts, who were between the ages of 30 and 62, and they got them to agree to come in every other year for a series of tests, blood pressure, things like that. And they followed these people over time. So the original Framingham population did not include any older women. If you were over 62, they didn't care to study you. When the study had been going on for enough time that they had a body of women who were over 65, they looked at the data again and found that, in fact, if a woman is over 65 and has angina, she has almost 3 times the risk of dying of coronary artery disease compared to men. Men with an angina have 2.4 times a relative risk of dying of coronary artery disease. And when they looked at the women who had angina, the women were more likely than men to have high blood pressure, diabetes, and heart failure, sometimes called congestive heart failure, where the heart isn't pumping enough blood for the body's needs. Now, we've also known for a long time that the onset of coronary artery disease is about 10 years later in women than men. And it used to be thought that this was due to estrogen. And that probably plays little, if any, role in the relative protection of women at least 10 years longer than men. My own personal bias is that it's due to our own innate biologic superiority, but I agree I might be biased. When they have coronary artery disease, women tend to present with angina. Men tend to present with an acute heart attack or a sudden cardiac death. So when a doctor talks about a heart attack or a myocardial infarction, this is what we mean. Remember, angina is a symptom. It's a diagnosis that you make on the basis of history. A heart attack is an event. And it's death of heart muscle due to interruption of its blood supply. And it's usually caused by rupture of that plaque in the artery. You can think of this plaque as sort of like a boil. It's an abscess. It's an abscess in the arterial wall. It even looks pussy. And if that plaque ruptures and that pussy plaque material gets exposed to the blood in the artery, the body tries to wall off that area by forming a clot. And when a clot forms, you may have a plaque that's only narrowing the artery 10%, but then a big clot forms when the plaque ruptures, and now your artery is 100% blocked, and the heart muscle downstream of that clot dies from lack of blood supply if its blood supply isn't restored in a period of time. And at most, you have a few hours to do that. So a heart attack is an event in which heart muscle dies. And there are usually characteristic changes in the electrocardiogram when that happens, and there are changes in certain blood tests that we do. Now, when I was in medical school, granted that was back in the dark ages, but I was taught that the typical symptoms of a myocardial infarction were crushing substernal under the breastbone chest pain, accompanied by nausea, shortness of breath, sweating, and a feeling of impending doom. And that's certainly true of most men. But women may have more subtle symptoms. They may have just nausea. They may have jaw, back, shoulder, abdominal, or neck pain, and they're more apt to present like that than men are. And they're more apt to have no pain at all, just shortness of breath, what we call a silent heart attack. They may be having a heart attack and not even know it. It may be picked up the next time someone does an EKG. And they're more apt to have fatigue and weakness than men are. Now, this was a very interesting study that was published by Jean McSweeney in Circulation, the Journal of the American Heart Association, back in 2003. Jean McSweeney is actually a PhD nurse. And what she did was she surveyed 515 women who had survived a documented heart attack. And she asked them various questions about prodromal symptoms. That means symptoms they might have been having in the weeks or months leading up to their heart attack. And she asked them about acute symptoms. And she found that in the months leading up to a heart attack, far and away, the most common symptom was unusual fatigue. And that scares me because I walk around fatigued all the time, or most of the time, and I'm sure you all do, and 100% of my patients complain of fatigue. But this was unusual fatigue. So if I see a patient who I know has a lot of risk factors for heart disease, and he or she, particularly if she tells me that she's unusually fatigued, she knows what her normal level of fatigue is, and now she can barely get out of bed in the morning, I get very worried, and I do some testing. I've had more than one patient who only unusual fatigue was a symptom that they were about to have a heart attack. Almost half had sleep disturbance. Over 40% had shortness of breath. 40% had indigestion. Over a third were anxious. And only 30% of women reported any prodromal chest discomfort in the months leading up to their heart attack. When she looked at the acute symptoms, when they were actually having the heart attack, shortness of breath was the predominant symptom in almost 60% of these women, followed by weakness, unusual fatigue, cold sweats, dizziness, back discomfort. And only just under 30% had the so-called typical severe chest pain. Now, we've known for a long time that women are more apt to die if they have a heart attack than men are. And the received wisdom was, well, that's because they're older. And it's true that women tend to have heart attacks at a later age than men. But Viola Vaccarino did a very interesting study where she analyzed data from over 150,000 women and almost 230,000 men between the ages of 30 and 89 who were entered in a National Registry of Myocardial Infarction, that's the second one, between 1994 and 1998. And indeed, the overall hospital mortality, that's people who died before they could even get out of the hospital for a heart attack, was 16.7% in women and 11.5% in men. And that difference is statistically significant. But then she did something very interesting. She looked at various age groups. And she found that among patients who were less than 50 years of age, women's mortality rate was more than twice that of men. Young women had a 6.1% risk of dying versus a 2.9% in men. And the difference in mortality was no longer significant after age 74. So if you look at older men and women, they're just as likely to survive or not survive. It's the younger women who were more apt to die than same-aged men. When we look at coronary artery bypass grafting, or what we abbreviate by calling it a cabbage, we've known for a long time that women are more apt to die than men when they have a cabbage. And Dr. Vaccarino looked at over 50,000 patients who underwent cabbage in the 1990s. Again, the received wisdom was, well, yeah, they're dying more often than men because they're older. She found that women under the age of 50 had more than 3 times the rate of dying postoperatively than men did. Women between the ages of 50 and 59 had more than twice the mortality of same-aged men. And just like with MIs, in patients who are 80 years of age or older, women and men had no difference no statistically significant difference in their mortality rate. And this difference in mortality rate persisted despite the fact that when you do a cardiac catheterization and you do an angiogram, you inject dye into the arteries and look at the arteries, women always appear to have less severe coronary artery disease. They had better heart pump function, but despite this, they had higher mortality. Now, this is a more recent article looking at a study out of Canada that took place between 1991 and 2004. Again, the women who came to bypass surgery were older. They had more comorbid conditions. In other words, they were more likely to have high blood pressure, diabetes, and heart failure. But they had better heart function, and they appeared to have less severe coronary disease. Over this time frame, 30-day mortality dropped from 2.4% to 1.9% in men, and in women from 5.6% to 1.9%. So we're getting better at operating on women. Overall, 30-day mortality was significantly higher in women if you looked along this whole 15-year time frame. But this difference was partly accounted for by differences in body size. And women tend to be smaller than men, and we have smaller coronary arteries. What about angioplasty? This is those balloon procedures where they put a special catheter into a coronary artery and blow up the balloon to open up a narrowing and may or may not put a stent in, which is a wire mesh that helps keep the artery open. There's a national registry of angioplasties, which we call PCI. That stands for percutaneous coronary intervention. Women in this registry had higher risks of stroke, vascular complications, because you're putting a foreign body in an artery, and were more apt than men to need repeat in-hospital procedures, even after they had adjusted for risks. Unadjusted mortality was higher in women, 1.8 versus 1.1%, but gender was not found to be an independent predictor of mortality after you adjusted for body size. But just as with CABG, we're getting better at doing angioplasty or percutaneous coronary interventions in women. This was a study that looked at gender-based differences in mortality after PCI over the last 25 years. And again, compared to men, women were older and more likely to have diabetes, high blood pressure, high cholesterol. It was a successful procedure in 89% of women and 90% of men. 30-day mortality significantly declined. And the conclusion of this study was that the 30-day mortality in men and women both have declined over the past 25 years. And after adjusting for baseline risks, there was no difference in either short-term or long-term mortality if you looked at men compared to women. And part of this is that finally they have appropriate sized catheters and appropriate sized stents to deal with the smaller arteries in women. So the Framingham study was undertaken to determine what the risk factors are for atherosclerosis. And risk factors are anything that increases your chance of getting a disease. And a risk factor can be either modifiable or non-modifiable. There are only two non-modifiable risk factors. One is age. You can lie about your age, but that doesn't modify it. And if you're a man who's 45 or older, or a woman who's 55 or older, you're at increased risk for atherosclerosis. And the other unmodifiable risk factor is your family history. You may wish you had different relatives. You may wish you had different genes. You might have wanted curly hair if you're like me and have straight hair. You might want straight hair if you have curly hair. But at least today, in 2010, you're more or less stuck with the genes you were born with. But all of these other risk factors, whether you're talking about smoking, abnormal levels of blood cholesterol, high blood pressure, diabetes, obesity, being a couch potato, something called metabolic syndrome, or inflammation, all of these other risk factors are either treatable or completely avoided. So let's talk about cholesterol. Very often I'll see a new patient And I'll say, why were you referred here? And they'll say, I have cholesterol. Well, we all have cholesterol. We wouldn't be alive if we didn't have cholesterol. It's a waxy substance that's found in every cell of the body. It's absolutely vital. It's used in the manufacture of many hormones, including our reproductive hormones. It's involved in digestion. It's found in the bile. But it's this waxy substance that can't be dissolved in water. And after all, blood is mostly water. So it circulates in the blood bound to special proteins called lipoproteins. Again, lipos is Greek for fat. So if you hook up this fatty substance with a protein, all of a sudden it can dissolve in the water. And we classify the lipoproteins based on their density when you spin them in a centrifuge. So we have LDL cholesterol, that stands for low density lipoprotein. We have HDL cholesterol, that stands for high density lipoprotein. And we have VLDL cholesterol, that stands for very low density lipoprotein. Now, some of you may know that there's something called good cholesterol, and that's your HDL cholesterol. If you can't remember, H stands for healthy. So your HDL, you want that to be as high as possible, because your HDL can actually go into a plaque, grab the bad cholesterol, remove it from the plaque, and take it back to the liver to be excreted. HDL cholesterol also has anti-inflammatory effects and antioxidizing effects, and oxidation and inflammation contribute to the formation of plaque. Bad, or LDL, remember L stands for lousy. So your LDL is your lousy cholesterol. This enters the blood vessel wall and starts the formation of the plaque. VLDL is mostly another blood fat called triglyceride. We'll talk some more about triglyceride. But about 20% of the VLDL molecule is cholesterol. So if you have very high levels of VLDL, that'll bring your cholesterol level up. And your total cholesterol is the sum of your HDL, your LDL, and your VLDL cholesterol. Now, one of the things that even very few doctors know, I'm going to let you know something that a lot of doctors don't know, is that elevations in LDL cholesterol are less predictive of cardiovascular disease risk in women than they are in men. On the other hand, high triglycerides and low levels of the good cholesterol are more predictive of atherosclerosis risk in women than they are in men. If you look at diabetes, it increases the risk of cardiovascular disease 3 to 7-fold in women. In other words, a diabetic woman compared to a non-diabetic woman has 3 to 7-fold increase in her risk, compared to 2 to 4-fold in men. If you have an elevation in C-reactive protein, which is a blood test that your doctor can order that measures the amount of inflammation that's going on in your body, elevations in C-reactive protein in women are more predictive of risk than elevations in the bad cholesterol. And smoking is the other risk factor that increases a woman's risk more than a man's. So diabetes and smoking are particularly deadly for women. Don't be, alarmed by this graph. It's really pretty easy. This is the relative risk of developing coronary heart disease plotted against your level of triglyceride, that other blood fat I mentioned, in men in the yellow and women in the blue. And this is from the Framingham study. The normal level of triglyceride is under 150. But you can see that if you're a woman, your relative risk of coronary heart disease increases significantly at a triglyceride level of 150 and above. And when you get to the higher levels, your relative risk, if you're a woman, is greater than your relative risk if you're a man, no matter what your level of triglyceride is in those higher ranges. What about smoking? Oops, I want to go back. Smoking, I tell my patients, is just a socially acceptable form of suicide. And the tobacco industry is the most successful organized crime syndicate in the world. Kills more people than any organized crime syndicate, makes bigger profits than any organized crime syndicate. It's the #1 preventable cause of heart attacks in this country. Joan and I just saw a very young woman today who was smoking 3 packs of cigarettes a day when she had her first heart attack in her 30s. Smoking is responsible for better than 400,000 deaths a year in the United States alone. Smoking increases atherosclerosis not only in the arteries supplying your heart, but in arteries all over the body. This is something else the tobacco industry doesn't want you to know. It increases your risk of developing diabetes. It lowers the age of menopause. This is sometimes how I can get young women to stop. It wrinkles and prematurely ages the skin, and I can tell a heavy smoker when he or she walks in the office the first time. It constricts the blood vessels in the skin. It thickens the skin. It causes wrinkling and a gray appearance. It's horrible. It would take another 2-hour lecture to talk about all the harmful effects of smoking, but I'll just hit the highlights. When you inhale carbon monoxide and about 200 other poisonous chemicals are released into your lungs and therefore into your bloodstream. Carbon monoxide and these other chemicals directly injure the wall of the artery. And when you injure an artery, you increase the amount of cholesterol that gets inside it. Smoking raises triglycerides and lowers HDL. And remember, that's a particularly risky combination for women. It increases your pulse rate and your blood pressure, so your heart has to work harder. It increases the likelihood of dropping dead suddenly. It makes the blood more likely to clot. So if you rupture a plaque, you're more likely to get a big clot there if you're a smoker than if you're not. It constricts blood vessels throughout the body. It increases that C-reactive protein and other markers for inflammation, and increases atherosclerosis throughout the body. This was a Danish study that looked at the median age of first heart attack in women who are non-smokers. Now, the median age is the age in the middle. In other words, half of the women were younger than that median age, half were older. And non-smoking women had a median age of first heart attack of 79. But if a woman was a smoker, her median age was 60. So smoking lowered the median age of first heart attack in women 19 years. When they looked at men, if you were a non-smoking man, you had your first MI at 71, and if you were a male smoker, at 64. And that is only a 7-year difference compared to a 19-year difference in women. This was a study involving over 11,000 women and over 13,000 men who were followed for about 12.5 years. And if you look at this is on the y-axis here, is the relative risk of a myocardial infarction or a heart attack, and this is the age. So if you're under 55 and you're a woman, your relative risk compared to a non-smoking woman increases almost 7-fold. If you're a man, it increases almost 3-fold. If you go across the age range, overall between the youngest and oldest ages, the relative risk of a heart attack was increased to more than doubled in women and almost 1.5 times in men. So smoking is more dangerous for women than it is for men. This was a study that looked at over 275,000 men and over 430,000 women who were 30 years of age or older. Among those who smoked 2 or more packs of cigarettes a day at the baseline in this study, women had a 74% higher rate of developing diabetes. Men had a 45% higher rate of developing diabetes. Women who quit for 5 or more years and men who quit for 10 or more years had essentially the same incidence of diabetes as those who had never smoked. So even if you've been a heavy smoker, it's important that you stop. You'll lower your risk. This is the Nurses' Health Study. This is another very famous study, which enrolled over 120,000 healthy nurses who were aged 30 to 55 at the onset of the study. And they were followed for many years. It's been we've gathered a wealth of information about women and heart disease from this study. And in this study, women who smoked just over a pack of cigarettes a day increased their risk of diabetes by 42%. compared to non-smokers. So the more cigarettes you smoke, the greater your risk of diabetes. Now, how do we diagnose diabetes? You can be walking around with diabetes and not know it. The only way to diagnose it accurately is to get a blood glucose measured in your blood. If you have fasted for 8 hours, and if your fasting plasma blood sugar level is 126 or more, you have diabetes. If you take a glucose load, or you eat a big meal, and you measure the blood glucose 2 hours later, and it's 200 or more, you have diabetes. Because the normal levels for fasting blood sugar is less than, it's less than 100. It's 99 or less. And for a random blood glucose, it's under 140. Now, people who are between the normal levels and the diabetic levels are said to have impaired glucose tolerance. And that's often a precursor for diabetes. So if you have impaired glucose tolerance, you need to make some changes. As I said, the risk of coronary artery disease in diabetic women is increased 3 to 7-fold in diabetic women compared to non-diabetic women. And diabetes takes away the cardiac protection that most women enjoy. Not all, but most women enjoy before the age of menopause. And diabetic women have a higher morbidity, that means a higher complication rate, and a higher mortality from coronary artery disease compared to diabetic men. So again, this is another one of those graphs from the Framingham study that looked at relative risk on the y-axis. This is comparing diabetic men to non-diabetic men. The blue is diabetic women compared to non-diabetic women. If you look at coronary heart disease in this cohort, women had a 3.7-fold increased risk compared to non-diabetic women. Diabetic men had a 1.5-fold increase in risk. If you look at peripheral arterial disease, that is blockages in the artery supplying the legs, diabetic women compared to non-diabetic women increased their risk 6.4-fold. Diabetic men compared to non-diabetic men 3.4-fold. If you looked at heart failure, diabetic women had a whopping 8 times greater relative risk than non-diabetic women compared to a 4.4-fold increase in diabetic men compared to non-diabetic men. This is, again, don't be intimidated by this graph. Along the y-axis, we have probability of event-free survival. So this is your probability over time of not having an event. And this is years of follow-up. And these were 27,000 women, more than 27,000 women, who were enrolled in the Women's Health Study. And it divided them into quartiles depending on whether or not they had a C-reactive protein above or below a median value of 1.3, and whether or not they had a median LDL level of 123. And not surprisingly, if you had high CRP, lots of inflammation in your body, and high levels of LDL cholesterol, you had a lower probability of having event-free survival. So you had a lower risk over 8 years of not having a heart attack. And not surprisingly, the women who had both low CRP, low levels of inflammation, and low levels of LDL had the best probability of event-free survival. But if you look at the intermediate groups, the women who had high CRP and low levels of bad cholesterol actually did worse than women who had low inflammation and high LDL. So if you're a woman and you have elevations in C-reactive protein, that's more of a risk than elevations in your LDL cholesterol. Now, I told you that women are treated differently, and we're going to go through some of the evidence. Good Lord, Ethel, you can't appear in public like that. One of the first studies that addressed this issue was published by Dr. Tobin in the Annals of Internal Medicine back in 1987. And he looked at 390 patients who had nuclear stress tests. That's a pretty accurate kind of stress test where someone has chest pain and you're not sure whether or not it's angina. You're not sure whether or not it's caused by a blockage in an artery supplying your heart. So these were all people who were not known to have coronary artery disease. There were 137 women, 253 men. 31% of the women and 64% of the men had abnormal nuclear stress test. But then he looked at what happened after they got that abnormal stress test. And he found that only 4% of women versus 40% of men with abnormal nuclear stress tests were referred for the so-called gold standard test of cardiac catheterization and coronary angiography. And this difference was independent of age and not explained by differences in rates of coronary artery disease. So men were 10 times more likely than women to get the definitive study. This was another study published by Leslie Shaw in the Annals of Internal Medicine back in 1994, and she looked at 840 consecutive nuclear stress tests done for chest pain in people who were not known to have heart disease. So these are all people who were thought to potentially be healthy. About the same percentage of patients, men in blue, women in red, had a positive test. Now, when a doctor says a positive test, that's negative for you, because that means it's abnormal, okay? But then she looked at what percentage of men and women had no follow-up testing. 38% of men had no follow-up testing. 62% of women had no follow-up testing after an abnormal nuclear stress test. And that was a highly statistically significant difference. She then looked at, over the next 2 years, the rate of either cardiac death or heart attack. And she found that 2.4% of men with a positive stress test either died or had a heart attack, whereas 6.9% of women with a positive stress test died or had a heart attack. And when she looked at how aggressively they were treated, whether they had an angioplasty or a CABG, 4.9% of men with an abnormal test had angioplasty or CABG compared to 2% of women. And again, those differences were statistically significant. This was a study that looked at people presenting with chest pain to an emergency room in West Virginia, Joan Lehman. And this was non-traumatic chest pain, again, in people who were not known to have coronary artery disease. This took out the people where you already knew the diagnosis. This is de novo chest pain. And the mean age was 50 for both groups. So, that's the age range where you have to worry. Even though men are still at higher risk at that age, women are at risk also. The American Heart Association, the American College of Cardiology, says that everybody who presents to an emergency room with chest pain needs an EKG, period. This study found that EKGs were done in 94% of men compared to 89% of women. Men were 3 times more likely to get a cardiology consultation, nitroglycerin, aspirin, and anticoagulants, that's things that help keep the blood from clotting, or thrombolytics, those clot busters, those clot dissolving medicines. Women were more likely to get narcotics and anti-anxiety medications. So the conclusion of the author was that although coronary artery disease is the #1 cause of mortality in women, those with new onset chest pain who present with similar symptoms as men are approached, diagnosed, and treated less aggressively than men are. So this is data from the year 2000. Although more women than men die of coronary artery disease every year in the US, we get 33% of angioplasty, stents, and bypass operations, 28% of those implantable defibrillators that can abort a sudden cardiac death, 36% of all open heart surgeries, and 27% of cardiac transplants. So what do we know about preventing atherosclerosis? I'm going to talk about some medication, cholesterol and lipid lowering. Lipid is the general term for blood fat lowering agents, aspirin, and what about hormones? I'm going to say a few things about lifestyle modification, namely exercise and a heart-healthy diet. what we know about treating abnormal lipids is that statins, those class of medications that include medicines like Lipitor and Crestor and Zocor and Pravachol, lower the risk of recurrent events in women who already have documented vascular disease. But statins are less effective in women than they are in men. They don't do as good a job in women as they do in men. Diabetic women may benefit from therapy with statins and/or another class of lipid-lowering medicines called fibrates, but unfortunately the studies are somewhat contradictory. One study will show that when you treat diabetic women with that combination, they do better. A study that just came out last week, you may have seen a lot of press about it from the American College of Cardiology meetings, showed that it didn't make a difference. It might even harm women. But here's a key fact, because I go ballistic when I get a 35-year-old woman without vascular disease referred to our Women's Cardiac Center on a statin because her bad cholesterol is a little elevated. There has never, ever been a study that showed that in women under the age of 65 who don't have diabetes or documented vascular disease, that statins lower your risk of having an event. And again, that's something that a lot of doctors don't even know. There's never been a study, and yet you'll see drug reps going to the offices pushing statins for everybody whose LDL is above whatever their goal is supposed to be. The Women's Health Study finally looked at the question of whether or not aspirin worked in primary prevention for women. Primary prevention is when you're trying to prevent the first event. So you collect a population of people that, as best you can tell, don't have the disease you're trying to prevent, and you treat half with an active medicine and half with a placebo, a dummy pill. And neither the patient nor the investigator knows which you're getting. It's called a double-blind, randomized, controlled study. And these are the studies that are most scientifically valid. Now, we've known for a long time that primary prevention with aspirin works in men. But people just assumed if it worked in men, you could apply it to women. When they finally got around to studying this issue, this was a study that came out in 2005 in the New England Journal of Medicine. They recruited almost 40,000 healthy women who were 55 years of age or older, and they were randomized to get either 100 milligrams of aspirin a day or a placebo. Now, a baby aspirin is 81 milligrams a day. This is every other day, sorry. So they were getting less than a baby aspirin a day, but it doesn't take very much aspirin to get the effect in helping prevent clots. And this is how aspirin works. It helps prevent clots. And they were followed up for 10 years for their first major cardiovascular event, either a non-fatal heart attack, a non-fatal stroke, or cardiac death. I always say we're pretty good at diagnosing death. We don't get that wrong often. So what did they find? At the end of the day, there was a non-significant 9% reduction in the risk of major cardiovascular events in these women, over 38,000. If you looked at the different composites of the different things that made up the composite endpoint, if you looked at the risk of stroke, there was a significant 17% reduction in the risk of stroke. But this was caused by a 24% reduction in the risk of stroke due to a clot in our artery supplying the head, but a non-significant, although it was significant to the person it happened to, increase in the risk of hemorrhagic stroke. When I say non-significant, it wasn't statistically significant. We're not sure that it might not just be occurring by chance. There was a 22% reduction in what we call TIAs, or transient ischemic attacks, where you have symptoms of a stroke, but they clear up within 24 hours. But there was no significant differences in the rate of fatal stroke, non-fatal or fatal heart attack, or cardiovascular death. But then they did something very smart, and they looked at the group of women who were 65 or older at entry into the study. Remember, you had to be 45 to get into the study. But when they looked at the subset of women who were 65% or older, they found that the risk of ischemic stroke, stroke due to clot, was reduced by 30%, and the risk of heart attack was reduced by 34%. So although aspirin doesn't seem to work for primary prevention in women before the age of 65, it does appear to have beneficial effects after the age of 65. Now, what about hormone replacement therapy? There were many observational studies of women after the menopause, and they showed that women who took hormone replacement therapy had about a 50% reduction in death from heart disease compared to women who didn't take hormone replacement therapy. Well, that sounds pretty impressive, right? The problem is that these studies were often biased by what we call self-selection. That is, women who elected to take hormone replacement therapy may have been healthier to begin with and may have had fewer risk factors than women who didn't take hormone replacement therapy. They certainly probably were better off socioeconomically because they could afford to pay for the hormone replacement therapy. And we know that low socioeconomic status is a risk factor for developing cardiovascular disease. So finally, they got around to doing a randomized, double-blind, placebo-controlled trial. And this was the Women's Health Initiative hormone study, which came out, was it 2002? And they collected over 16,000 women who didn't have documented vascular disease and who still had an intact uterus, but were postmenopausal. And they randomized half of them to a placebo and half to get Prempro, which was the most common hormone replacement therapy that was prescribed in the United States. It's a combination of estrogen and progesterone. Now, if you just give a postmenopausal woman who has her uterus intact estrogen at the menopause, you significantly increase her risk of uterine cancer. Not a good thing. But if you give such a woman estrogen and progesterone, you eliminate that increased risk of uterine cancer. So they took these over 16,000 women, half got placebo, half got Prempro. And the study was stopped prematurely. Every study like this has a data monitoring and safety board who aren't blinded, and they meet on a regular basis to go over the data. And if they reach a certain amount of benefit or a certain amount of harm, the study is stopped prematurely. In the Women's Health Initiative hormone study, it was stopped prematurely for harm. What did they find? Overall, the risk of breast cancer, this is number of cases of breast cancer per 10,000 patient years. Okay, so if you followed 10,000 patients for 1 year, or one patient for 10,000 years, if you could find someone, the women who were on estrogen plus progesterone had 38 cases of breast cancer compared to 30 in the women on placebo. Not only did hormone replacement therapy after the menopause prevent heart attacks, it increased your risk of heart attack. 37 heart attacks per 10,000 patient years in women on HRT compared to 30 in the women who were on placebo. If you looked at stroke, 29 per 10,000 patient years strokes in women on HRT, 21 in those who are not. If you looked at all blood clots, like blood clots in the legs, blood clots in the lungs, 34 compared to 16. The only benefits were a decrease in hip fractures and colorectal cancer. But if you looked at the overall risk-benefit ratio, they had to stop the study. They felt it would be unethical to continue. Now, there have been multiple criticisms of this study, mostly, I think, prompted by the drug companies, who lost a tremendous amount of money when women went off their HRT willy-nilly. And there are some unanswered questions, because many of these women were 10 years postmenopausal. And we don't usually put women on HRT 10 years after the menopause. But some of the unanswered questions are, does timing affect the results? That is, might HRT be protective if it starts sooner after menopause? And after multiple analyses of this study and other studies, the most recent analyses would suggest that the answer is no. How long is it safe to take HRT? Because there are women who are basically made miserable by hot flashes. And the most effective treatment for hot flashes is hormone replacement therapy. Although my personal bias is if you exercise hard enough, you're not going to have any sweat left to have hot flashes. We don't know the answer to this. It seems like if you have to take estrogen or estrogen and progesterone to be able to function because you're so crippled with hot flashes, you take the lowest possible dose for the shortest period of time. And does the type or dose of hormone used make a difference? We don't know. Probably the higher the dose, the worse. But no one's going to do the randomized trials to test that. At the Women's Cardiac Center, when we're advising women to stop their HRT, and they're taking it every day, we say, all right, for 1 month now, we want you to take 6 a week. Instead of taking 7 pills a week, we want you to take 6 pills a week. And then after a month on 6 pills every week, go down to 5 pills every week and stagger the days you're off. And then the next month, go to 4 pills a week, and then the next 3, 2, and 1. And I don't think we've ever, Patty or Joan can correct me, I don't think we've ever had a woman who couldn't get off hormone replacement therapy. You do it that way. Because it's not just the absolute level of estrogen that determines the hot flashes, it's how rapidly it's dropping. And if you drop very slowly, you'll be fine. When I started going through the menopause many years ago, this was before these studies came out, and I thought about it, and then I looked at my aunts. And my mother was one of 11 children. All of her siblings who smoked died young. Her sisters who didn't smoke made it into their 90s. And they never took hormones. They never took a statin. So I said, Barb, you'll probably be fine if you don't take hormone replacement therapy. So, but what we do know for sure is that hormone replacement therapy has no protective effect. My own personal bias is that the protective effect of estrogen on the vascular system is very age-specific. Mother Nature is no dummy. And estrogen protects you during your reproductive years. And just like we wouldn't dream of putting a 5-year-old girl on estrogen, we shouldn't dream of putting a 65-year-old woman on estrogen and progesterone. They're beneficial while we're reproducing, and not before and not after. So exercise. Regular aerobic exercise lowers your blood pressure, improves your cholesterol profiles, lowers your blood sugar, decreases your likelihood of clots, and lessens insulin resistance. A lot of the diabetics we see who are diabetic because they're obese make plenty of insulin. They make more insulin than a normal weight person does, but their body has become resistant to that insulin. Now, like everything else, women have been underrepresented in studies of exercise and coronary artery disease, but one of the best studies was a prospective study that followed over 3,000 women for 8 years. And if you looked at the age-adjusted death rate from cardiovascular disease, in the most fit women, it was 0.8 per 10,000 person years, compared to 7.4 per 10,000 person years among the least fit. So again, that's death rate, and we don't often get that wrong. So I tell my patients that exercise is the fountain of youth. If I didn't exercise, I would either be in Butler Hospital or the ACI. Not sure which, but one or the other. Unfortunately, only 1 in 4 women gets the recommended 30 minutes of exercise at least 5 times a week. 1/2 of women who are at the greatest risk get no exercise at all. Regular exercise also lowers a woman's risk of stroke, breast cancer, osteoporosis, and hot flashes during menopause. So what I don't understand is why anyone would not exercise. So just a few words on diet. This is another area where there's been so many myths and so much misinformation. Anyone who tries to put you on a low-fat diet, get another doctor. Low-fat diets are bad for the heart. You need to be on a diet that incorporates enough of the heart-healthy fats. And you need to be on a plant-based diet. A heart-healthy diet is a plant-based diet. You need to be eating lots of colorful fruits and vegetables. You need to be eating whole grains, and olive oil should be your main source of fat calories. When Ansel Keys did his famous 7-country study back in the 1950s, he found that the lowest rate of cardiovascular disease was in Crete, the island of Crete. 45% of the calories in the average Cretan diet came from fat, but it was all olive oil. Remember that chicken is meat. I tell my patients, if it doesn't grow out of the ground or live in the water, don't eat it. We try to get everybody on a seafood vegetarian diet. You need to eat fatty fish like salmon and trout. You don't have to worry about mercury if you avoid the fish at the top of the food chain like tuna and swordfish. And you need to avoid these manufactured trans fats. It's very hard to avoid them if you eat processed foods or if you eat out in restaurants. These partially hydrogenated vegetable oils raise the bad cholesterol and lower the good cholesterol. And the label, thanks to our congressmen who get bought off by the food industry, can say zero trans fats if there's less than 500 milligrams per serving. Who stops at one serving? So you have to read the list of ingredients. Even if it says zero trans fats, if any of the ingredients say partially hydrogenated vegetable oils, don't eat it. Boycott it. They'll get the hint after a while. So the heart-healthy fats are the monounsaturated fats and the omega-3 fatty acids. The omega-3 fatty acids in high doses, these are the ones that are found in fatty fish and certain foods like walnuts, flaxseed, hemp seed, and canola oil, lower triglycerides and protect against sudden cardiac death. The monounsaturated fats, such as found in olive oil, canola oil, and they're also high in fish, raise the level of the HDL cholesterol. So if we see a man or a woman in the Women's Cardiac Center who has a low level of HDL cholesterol, the first thing we say is, you need to take in 2 to 3 tablespoons of olive oil a day. And I don't care whether you take it by the spoonful or put it on everything that goes in your mouth, but that's how much you need. And it always works, and there are no side effects on the liver or the muscles. These are the fats to avoid like the plague: saturated fat, animal fat, dairy fat. The only 2 vegetable oils that are high in saturated fats are palm oil and coconut oil, and those partially hydrogenated vegetable oils. So if you have these at home or these at home, get rid of them if you're interested in staying heart healthy. So what questions do you need to ask your physician? You need to say, what are my risk factors? What can I do to prevent cardiovascular disease? Are there programs to help me quit smoking, to exercise, or to improve my eating habits? Are there educational programs like this one, specific to women? And what, if any, kinds of tests do I need to evaluate my cardiovascular status? Because when you get right down to it, preventing cardiovascular disease is very easy. If you smoke, stop. If your cholesterol, blood pressure, blood sugar, or weight is high, get it down. Exercise 30 minutes a day, eat a heart-healthy diet, and pick your parents wisely. And I guarantee if you figure out how to do that, the Nobel Prize Committee will be knocking on your door. So in summary, there are gender-specific differences in atherosclerotic cardiovascular disease, including age of onset, risk factor weighting, responses to medications and interventions, symptoms at presentation, and mortality. I used to think I could diagnose coronary artery disease in women. The older I get, the harder I find it to do, because women have atypical symptoms. Coronary artery disease may be harder to diagnose in women, and their outcomes from various interventions may be worse than that of their male counterparts. So that's the end of my slides, but I think my voice will hold out for some questions if there are any. Thank you. Yes?
I think I might have missed a little bit that you said about dairy products. How about skim milk?
Skim milk is fine. Skim milk has no fat in it. We allow our patients skim or 1% milk. Yes? Oh, yeah, I'm sorry. The question was, what about skim milk? Skim milk is great. Yes?
The medicine over the counter,
cholesterol off?
Yeah. It's over the counter? I don't know.
I don't know what's in cholesterol off, but I'll tell you, if it's not prescription, it's not regulated by the FDA, and no matter what the label says, you really don't know what you're taking. I was at the American College of Cardiology meetings earlier this week, and there's something called red rice yeast that a lot of my patients who just want to take natural things take. Now, red rice yeast works in lowering your cholesterol because it has a statin. There was a study presented at this meeting that looked at various red rice yeast preparations, and the amount of statins varied tenfold. Also, the other ingredients were very variable, and several of those sampled had a chemical that's toxic to the kidneys. So, I think you're very courageous to take over-the-counter supplements and herbs. I mean, if you go to a reputable company, take your vitamin C, take your calcium with D, you're probably okay. But if you're taking these herbs and natural supplements, you don't have a clue what you're taking. Yes?
What is your recommendation about routine ordering of CRPs?
Very good question. What do I think about routine ordering of CRPs? We don't do it. I'll tell you when we do it. When we have someone who may not have documented vascular disease, but has a lot of risk factors, and their LDL and their HDL and their triglycerides are hovering higher than we'd like to see it, or their LDL is lower than we'd like to see it, and we're thinking about maybe putting them on a medication, we will get a CRP to help us decide whether or not they may benefit from a statin. Now, there was a study published, first came out about 2 years ago, called the Jupiter trial. It was the largest primary prevention trial using a statin, and it looked at a statin called Crestor. Before this trial, there had been 3 primary prevention trials of statins. In other words, you take a bunch of people who don't have vascular disease, but you think they're at increased risk, whether because they have high bad cholesterol or low good cholesterol or whatever. You treat half with placebo and half with statin. The first of these studies was called the West of Scotland trial, had no women. The second was called the AVCAPS-TEXCAPS trial. It had 15% women. The third was something called the ASCOT lipid lowering arm. That had 19% women. So if you looked at those 2 trials that had women, the number of women came to just under 3,000. And if you looked at the number of primary endpoints in women in those trials who were on statin or placebo, there was no difference. Unlike men, where the men on the statins compared to the men on placebos had a lowering of their event rate. The Jupiter trial recruited over 6,000 women and over 11,000 men, healthy men. But to get in the trial, if you're a woman, you had to be 60 or older. And you had to have a CRP of 2 or more. And you had to have a bad cholesterol under 130. Because the feeling was if your LDL was over 130 and you had other risk factors, you should probably be on a statin anyway. So everyone in the Jupiter trial had a CRP, that inflammatory marker, that was elevated. It was 2. Normal, low risk is under 1. And their LDL cholesterols, not on any medicine, had to be 130 or below. When the study was first presented a couple of years ago at the American Heart Association annual meeting, they showed that both men and women had a significant lowering of their risk of the primary endpoint. The primary endpoint was a composite made up of non-fatal heart attack, fatal heart attack, stroke, those acute coronary syndromes, and need for revascularization. And for almost 2 years, I tried to get the absolute numbers on women, because they didn't give the number of events in women. They gave the overall number of events in placebo versus statin treated. They finally published the paper about a month ago, giving the numbers in women. And if you look closely, The only significant difference was a decrease in the quote-unquote need for revascularization, which is a very soft endpoint. There was no significant difference in the rate of heart attacks, no significant difference in the rate of death in women on placebo or statin. There was a decrease in the need for revascularization. And I can tell you from my own personal experience that I have had women patients of mine, for example, go to Florida, they have chest pain that if the doctor had bothered taking a history was clearly not angina. They go to the cath lab, they see a blockage, they do a procedure. They open it up. Of course, their chest pain continues because their chest pain wasn't angina to begin with. So that's the kind of thing it's hard to control for, and it's a very soft endpoint. In addition, it was only significant, the primary endpoint was only significant in women 65 or older. So you had to be 60 to get in the trial. But the significant difference in that composite endpoint, which had some soft features, was only in women who are over 65. That's why my slide said in women without documented heart disease, who don't have diabetes and are under 65, we have no evidence that a statin is beneficial. Did I answer your question? Okay. Yes?
You mentioned if it grows out of the ground or if it swims. Where does shrimp and lobster fall?
Shrimp and lobster are great.
They're fine.
Yeah. They have cholesterol, but eating cholesterol doesn't raise your cholesterol. It's eating saturated fat that raises your cholesterol.
And if you can't eat enough spoonful of olive oil, are fish oil tablets?
Fish oil tablets are high in omega-3 fatty acids. They, in high doses, will lower triglycerides. They have a slight effect on raising HDL, but not as much as the monounsaturated fats. You can use canola oil if you don't like the taste of olive oil. Yes?
My only other question is, if you're on a blood thinner, is the olive oil still okay?
If they're on a blood thinner, is the olive oil still okay? Yes, even Coumadin and aspirin. Some surgeons think that taking fish oil supplements increases your risk of bleeding during surgery. I haven't seen any really good studies that prove that. But, if the surgeon wants to stop fish oil for a week prior to operating, you're not going to get into trouble in that period of time from stopping your fish oil. Yes?
One thought about treatments. Why are women treated differently than men? I don't understand why we're not given equal treatment.
It's not just in cardiology. The question is, why are women treated differently? That's a tough one. I would have to defer to my colleagues in the women's study department who probably know better than I. We live in a patriarchal society. Power is in the hands of men. No matter whether you're looking at Wall Street, the government, medicine, women have made tremendous strides. I have been lucky to have had some incredible male mentors. I have a wonderful husband. I'm not one of those man-hating feminists. But I don't think that we can deny that just as racism exists, sexism still exists. Now, most doctors don't set out to discriminate against women. But they have done studies using actors and actresses, having doctors interview these. It's part of a study. They know that this is an actor and actress. And giving the same history, but the woman who was very calm and businesslike was more apt to get referred for testing with the same symptoms as the woman who was like histrionic and hysterical. We have certain built-in biases. And we know that women tend to present later. So sometimes doctors don't want to think that their younger female patients might be having heart disease, just as the women don't want to. It's known that women having a heart attack wait much longer, whatever their symptoms are, before they go to the emergency room than men do.
Two more questions.
Two more questions.
First, I'd like to actually thank you for providing us with
Thank you.
Second, I'd like to know, as it relates to gender-specific differences, where does race and ethnicity fit in some of these?
Excellent question. Actually, young African American women have a higher risk of cardiovascular mortality than any other group. The interesting thing is that they tend to have lower levels of bad cholesterol than Caucasian women. But African American women have a higher incidence of diabetes and a higher incidence of high blood pressure. And that's thought to contribute to their increased risk. Did I answer your question? Yes.
The CRP inflammation that you spoke of, does aspirin or anything else treat that?
You know, I haven't seen a randomized controlled trial of aspirin. Statins are known to lower CRP. And if you look at all of the statin trials, those cholesterol-lowering medicines, the most benefit seems to accrue to the people who lower their CRP the most, lower their bad cholesterol the most.
And is it, but there's no other way to do it? Exercise, diet, or anything?
Yeah, there are, if you smoke, yes, if you smoke, stopping smoking lowers your CRP because smoking increases inflammation throughout the body. If you're overweight, particularly if you have what we call visceral or abdominal obesity, and you diet and exercise that off, you'll lower your CRP. Regular exercise lowers CRP.
Thank you very much, Barb, for really stunning. Thank you. That really